Hello, my name is Mariam, and today I'm going to be teaching you about pericardial diseases. So let's go back a bit and talk about the anatomy of the pericardium so you're better able to understand the pericardial diseases. So what is the pericardium? The pericardium is a fibrous sac that encloses the heart and its great vessels. Its function is to keep the heart in a stable location in the mediastinum. It facilitates its movement via lubrication with pericardial fluid, and it separates it from the lungs and other mediastinal structures. It's composed of two layers, the fibrous pericardium and the serous pericardium, which I'll show you on the next slide. Here you can see the two main layers, the tough external layer known as the fibrous pericardium and the thin internal layer known as the serous pericardium. The fibrous pericardium is continuous with the central tendon of the diaphragm and is made up of a tough connective tissue that is relatively non-distensible. Its rigid structure prevents rapid overfilling of the heart, but it can contribute to serious clinical consequences like cardiac tamponade, which I will be explaining later on. The serous pericardium is enclosed within the fibrous pericardium, as you can see here, and it itself is divided into two layers. The outer layer that lines the inner surface of the fibrous pericardium, and the internal visceral layer that forms the outer layer of the heart, which is also known as the epicardium. Each layer is made up of a single sheet of epithelial cells known as mesothelium. Now found in between the outer and the inner serous layers is the pericardial cavity, which contains a small amount of lubricating serous fluid. This fluid serves to minimize the friction generated by the heart as it contracts. Now we can talk about the pericardial diseases. They are almost always secondary to other heart pathologies or systemic diseases. Isolated pericardial disease is unusual, and when it occurs, it's usually due to a viral infection. They can be broadly categorized to two types: pericardial fluid accumulation and pericarditis. Here I've also written cardiac tamponade as it is a complication of the fluid accumulation. Normally, in the pericardial cavity, we have around 30 to 50 milliliters of a clear watery fluid. If it accumulates slowly, the pericardium has time to dilate, so even up to 500 milliliters can accumulate without clinical significance. And the only difference that would show up would be enlargement of the heart shadow on the chest radiograph. If it accumulates rapidly, like for example in an aortic dissection, 200 to 300 milliliters of accumulations can already be very clinically devastating, as it could cause cardiac tamponade. So for your exam, you need to know the types of pericardial effusion. So here we have serous, which is the most common effusion, and it's a clear, watery, straw-colored transudate. Transudate meaning it's due to the squeezing of the plasma through the membrane. So the transudate won't have a lot of protein, it would be low in protein. And this occurs in conditions due to generalized edema, for example, like chronic heart failure or hypoalbuminemia, because you'd have decreased oncotic pressure. And that, for example, could happen due to renal, nutritional, or hepatic causes. You can also have serosanguinous effusions, and that contains serum and blood, and that can occur due to blunt chest trauma, malignancy, ruptured MIs, aortic dissections. You can also have chylous effusions, which are milky, and they're due to mediastinal lymphatic obstruction, and that could be, for example, due to a tumor that's obstructing the lymph. You can also have cholesterol effusions, but these are very rare, and they're characterized by the presence of cholesterol crystals, such as in myxedema. Now, hemopericardium is the accumulation of just pure blood, and it usually happens very suddenly and quickly. And causes of it could be ruptured of the heart, like due to myocardial infarction, could be due to aortic dissection, trauma following CPR or laceration of the coronary arteries, could be due to a bleeding diathesis such as thrombocytopenia, which is a deficiency in the platelets, and this would lead to cardiac tamponade. Cardiac tamponade is a clinical syndrome caused by the accumulation of fluid in the pericardial space, resulting in reduced ventricular filling and subsequent hemodynamic compromise. The condition is a medical emergency, and the complications of which include pulmonary edema, shock, and death. So for the symptoms, you can see Beck's triad, which is a combination of hypotension, muffled heart sounds, and that's due to the fluid in the way, distended neck veins due to the reduced filling of the heart. You can see electrical alternance, which is an alternating voltage of the QRS complex, and that occurs due to the swinging movement of the heart within the effusion from the beat to beat. And you can see that on the bottom left. You can also see pulsus paradoxus, which is a fall of more than 10 millimeter mercury in blood pressure during inspiration. You can also see Kussmaul's sign, which is a paradoxical rise in the jugular vein pressure during inspiration. So pericarditis is inflammation of the pericardium, and acute pericarditis typically manifests with a low-grade fever, a pleuritic chest pain, and a pericardial friction rub and auscultation. You need to know these several types for your pathology exam. So starting off with serous pericarditis, it's a serous effusion having increased protein content. The inflammatory reaction results only in a low increase in vascular permeability, but if severe, it progresses to fibrinous pericarditis. Causes are usually a non-infectious inflammatory pathology, such as viral infections or an autoimmune disease or a malignant tumor. And the morphology of it is a very mild inflammatory infiltrate with predominantly lymphocytes. Next, you have fibrinous and serofibrinous pericarditis, and this is the most common pericarditis. It causes larger damage and leads to even higher vascular permeability. Therefore, fibrin can leak into the pericardium, and often in the exudate, it's a mixture of fibrinous exudate with serous exudate, and it presents with a very loud friction rub. Causes could be Dressler syndrome, which is secondary pericarditis in the setting of injury to the heart or the pericardium, for example, post-myocardial infarction. It can also happen due to uremia, trauma, or autoimmune diseases. The morphology of the serofibrinous pericarditis, you'd see the yellow-brown turbid fluid due to the presence of white blood cells, red blood cells, and fibrin. And when this heals, in mild cases, you can see complete resolution, but in more severe cases, it is organized and it develops fibrous adhesions, and that can result in adhesive pericarditis. Third, there is suppurative or purulent pericarditis, and the exudate contains pus, mainly caused by the pyogenic bacteria invasion of the pericardial cavity. Examples of this bacteria could be staphylococci or streptococci, and less frequently it could occur due to fungi and parasites. And it's most common in immunosuppressed patients. The causes are basically spread of the infection to the pericardium. It could be from neighboring infections like empyema of the pleural cavity, or hematogenous spread, or lymphatic spread, or it could be even direct inoculation in cardiac surgery. And as you know, wherever bacteria go, neutrophils will go. So the morphology, you'll see a very high infiltrate of neutrophils. And healing for this pericarditis, it generally doesn't resolve completely, and it heals with organization, resulting in scarring that frequently produces constrictive pericarditis. Fourth, we have hemorrhagic pericarditis, and its exudate is composed of fibrinous or suppurative effusions in blood, and it arises due to damage to the surrounding vessels. and the damage to the surrounding vessels could be caused by spread of a neoplasm, and that's the most common cause, or it could be like thrombocytopenia, or it could be tuberculosis or a severe acute infection. And the clinical outcome is similar to that of fibrinous or purulent pericarditis. If pericarditis lasts longer than 3 months, it is called chronic pericarditis, and it is characterized by thickening and rigidity of the pericardium. Here I've written some types that you need to know for your exam. First one being tuberculous pericarditis, which occurs due to extension from tuberculous foci that are nearby, or due to lymphatic spread from the bronchial lymph nodes. And it causes granulomatous inflammation of the pericardium. Macroscopically, you can see cheese-like material, and you can see tubercles. Microscopically, you can see tuberculous granulomas with caseous necrosis on the pericardial wall. Next, you can see pericardial plaques, which are organizations with fibrous areas on layers of the pericardium. Third, you can have adhesive pericarditis, which occurs due to organization and healing by formation of fibrous adhesions in the pericardium after fibrinous, suppurative, or hemorrhagic pericarditis. It begins with granulation tissue and neovascularization, and then fibrous adhesions develop between the visceral and the parietal layer. And this usually doesn't impair the work of the heart much, but when it becomes adhesive mediastinopericarditis, the fibrous adhesions develop between the parietal pericardium and the adjacent mediastinum. And with every beat, the heart has to work much harder because it has to move these mediastinal structures that it's attached to. And eventually, for the heart to do so, it will hypertrophy, and it will lead to dilation, and onward, it would lead to congestive heart failure. And this would be due to systolic failure because the heart cannot contract. And fourth, you can have constrictive pericarditis, and it is the dense fibrous thickening of the pericardium, resulting in mechanical interference with the function of the heart and decreased cardiac output. This leads to diastolic failure because the heart cannot be filled properly, and this can result from long-standing of any of the acute conditions, so any of the acute pericarditis. And treatment of this would be surgery to remove the fibrous pericardium so it wouldn't compress the heart anymore. Thank you and good luck in your exams.